1. We are live.
Good.
Good evening, friends. On behalf of Uttaranchal Orthopedic Association, we welcome you to the unusual topic of non-operative treatment of avascular necrosis hip. Friends, as we have gone through the corona epidemic, has been a surge in the cases of avascular necrosis due to the usage of steroid in large doses and for long times. So let me first introduce you to our faculty, Dr. Arvind Jain Diwakar from Lalitpur, UP. Welcome you, sir. Dr. Aroop Mukherjee from Max Saket. Welcome you, sir. Dr. L. Prakash, the well-known orthopedic surgeon of this country. We are very proud to be with you, sir, in this webinar. Dr. Puneet Agarwal, our dynamic secretary from Uttaranchal Orthopedic Association. We welcome you and we welcome all the audience listening to the webinar. Sir, as I had been going through the reports of AVN surging throughout the country, the thought came to me, and Dr. Diwakar Jain and Dr. L. Prakash enlightened me about it, and then I contacted Dr. Aroop Mukherjee, and so that thought of this topic came. This is an unusual topic for surgeons, but if we can achieve something without surgery, it's well and good. So I invite Dr. Aroop Mukherjee for his talk on Mukherjee regime for AVN hip. Dr. Aroop Mukherjee, please share your screen and start the talk.
Good evening, all of the delegates and the members who are attending this meeting. Let me share my experience with you all because as you rightly mentioned, because of the surge of avascular necrosis recently after the corona pandemic, this has been a concern worldwide how to manage the complications of avascular necrosis, as it is affecting a younger population, or we can say in whom a joint replacement is not advisable or feasible. Not many people can really afford joint replacement. Not many people are included in the indication of joint replacement. We have to stretch our indications beyond the age limit to say that we have done a joint replacement. Now, the thing is that why does this happen is the biggest question. Avascular necrosis is a chapter of idiopathic group, just like what we see as a chronic kidney disease, CKD. That is the
please share your screen also, sir.
Yes, just a minute.
The green button in the bottom, sir. Yes, it is there, sir.
Now the thing is, let us discuss about this mysterious topic of avascular necrosis of the femoral head. Because nobody is sure about the etiology, that is the reason there are so many treatment available with this. So the thing is that when it was not a pandemic, when young people of arthritis were not so much affected in the general population, then avascular necrosis was not that much prevalent as it became after the pandemic of coronavirus. What is the association between a pandemic and avascular necrosis? I'll just explain you in a minute. Now let us just quickly revise the difference between ischemic necrosis is aseptic necrosis, that means there is no infection, as compared to septic necrosis, which forms a sequestrum. A sequestrum cannot be reversed, but an ischemic necrosis, aseptic necrosis, can be reversed, because a dead bone is an area of a bone which is devoid of living cells, but the structure is the same. I think it is clear by this time. The fact is, the facts and myth about the bone death is the bone never dies due to ischemia. It will come to life again, because when we say bone, we mean the structure of the bone. A bone which is dead without of live tissues, live cells, living cells, or the living cells are replaced by fat cells, that means the structure is intact, but the bone is temporarily died, but will come to life again. If you maintain the structural integrity, the same dead bone will come to life again. Now the cartilage, we are so concerned about a joint, draws its nourishment from subchondral bone and the synovial fluid. Let us quickly go through the blood supply of the femoral head. Now, the femoral head is supplied by a circle of blood vessel around the base of the neck. There are anterior ascending retinacular vessel. There are posterior ascending retinacular vessel. The anterior ascending retinacular vessel, if you can see that, draws its blood supply from a main branch of the lateral circumflex femoral artery, and the posterior draws its blood supply from the medial femoral circumflex artery. In most of the population, in 80%, 70 to 80% of the population, the lateral femoral circumflex artery is the main blood supply, but both the blood medial and lateral circumflex femoral artery make a good supply to the femoral head. But in 20% of the population, the medial is the important or the main vessel, and the lateral is missing or it is very vestigial. That is the reason it is solitary supplied by the medial circumflex femoral artery, which supplies principally the back side of the femoral head. The front side is practically devoid. When in thrombosis or when there is a vascular blockade of the medial or the solitary blood supply, then the anterior part of the femoral head dries up or goes into ischemia. And that is what we see in most of the cases, that the anterior and superior part of the femoral head has gone into ischemia. See, this is the posterior part, and this becomes, this is the only prevalent area. This is the solitary blood supply. When this is blocked, then the anterior part also dries up. And that is the reason we see that most of the AVN comes on the anterior and superior part of the femoral head. So in 20% of the population to 30% of the population in different studies by Toyota, it is said that one of the blood vessel is missing. And this is the vulnerable population who are prone to avascular necrosis. That is the reason that all the patient don't suffer from ischemia. When they have got the double blood supply, they don't suffer from it. But patients who have got, or the population who has got single blood supply, also suffer from thrombosis, and that is the reason they go into avascular necrosis. Now, what is the cause of thrombosis? Thrombosis at all levels is seen in arthritis patients. That means a thrombosis can precede arthritis by many months. A thrombosis can be seen during arthritis and after arthritis also. And thrombosis happens at all levels of the blood vessels. That means arterial, arteriolar level, like venous congestion, capillary level. And that is why we see venous thrombosis of the lower limb so commonly associated with hip and knee arthritis, and the risk of pulmonary embolism after joint replacement surgery. And that is the reason we give low molecular weight heparin or enoxaparin as a rule to all of these patients to avoid fatal pulmonary embolism. But minor pulmonary embolism happens in 80% of the patient. That may not be fatal. So this is what the message is, that arthritis causes thrombosis, and thrombosis is at all the levels, in arterial level, arteriolar level, venous congestion, capillary level. So in all the patients of arthritis, you will see thrombosis. Now, those patients suffer most from thrombosis where there is a single blood supply or a solitary blood supply. So here is the reason that we can know that not all patients have solitary blood supply. About 20 to 30% of the population has blood supply which is mostly bilateral, in which medial femoral circumflex is dominant and the lateral femoral circumference is weak or absent. This matches exactly to the number of AVN or non-unions seen after fracture neck of femur intracapsular. Why? What is the role of steroid? Why it is blamed that the steroid given in these patients have caused this? Now, unprotected heavy doses of steroid always causes amyloidosis in arthritic patient. Amyloid is a material which is deposited inside the blood vessel. Whenever there is a solitary blood supply, this gets blocked. So we see this more commonly in patients who have been subjected to steroid intake. So the patient with solitary blood supply to the femoral heads are vulnerable to AVN due to arthritis and steroid intake. Why? Because arthritis, these patients who are vulnerable to arthritis are also vulnerable to coronavirus. So that is the reason. Why does arthritis flare up? Because of the viral infections, whether it is chikungunya, whether it is coronavirus, even if it is herpes, that arthritis will flare up. So the message is that thrombosis can precede the clinical arthritis, as we see fatty liver years before clinical arthritis. There are two types of AVN. AVN with primary synovitis in the same joint. That means the synovitis in the hip joint is pressurizing on the blood vessels, solitary blood vessel, and which is causing synovitis as well as diminution of the joint space. That means destruction of the joint, and arthritis also in a different stages and the loss of joint space. And then AVN with primary thrombosis of the blood vessel with various stages of AVN without loss of joint space. Here, arthritis is in the hip in the knee, but the blood vessels of the hip have gone thrombosed. So here we see primary AVN without loss of joint space. Now here is the example. We see that the right side of this femur has got both arthritis as well as AVN. Whereas on the left side, we see that the joint space is intact and the AVN is also there. So in the same patient, we can see both the things together. See, with the treatment, what happens? This was the Mukherjee regime when we started this many years ago. And this is a standard prescription which I suggest to all my fellow colleagues and junior colleagues who start the treatment. Now with this treatment, which is what? Which is a prescription containing low doses of disease modifying drugs. These disease modifying drugs along with a blood thinner regresses the arthritis as well as the thrombosis. So this is the message, that when you give low dose DMARDs to the patient, so their arthritis regresses, their thrombosis reverses, and the blood supply of the femoral head resumes. Now, I already told you that the bone never dies. So the ischemic bone then starts collecting the blood flow again bit by bit, and the circulation is established. And in science, we know there is a word called creeping substitution, which happens from the periphery to the center and the core of the femoral head. The femoral head may be size of a 40 millimeter to say 55 millimeter size. So it takes a little longer time for the remodeling and for the creeping substitution to vascularize the whole part. The blood thinner improves the circulation, as well as the arthritic regime is such that this regime can be taken for 2 years without any without any side effect or adverse effect. Only thing, having said that, I always say get a blood test, or get every 3 months, every month to start with, and every 3 months later on, because this combination of medicine is widely used and widely suitable to all the arthritic patients. So I am relating avascular necrosis with arthritis and thrombosis of the blood vessel. See, this is the same patient who got the same the same X-ray of the patient lady who got the same treatment. See, in a 6 months time, you see that the left hip joint head of the femur has cleared up quite well, and the right also did not collapse, although it was perfectly on a verge of collapse. But with the treatment, see, you see that there is a thin fibro cartilage developing around the femoral head, and the patient has got significant pain relief, as well as she has started developing range of motion. See, this is absolutely, see, the left side is nearly normal. The right side has developed joint space. I'm showing this particular case because in this case, the same treatment is giving you results in both the type of AVN presentation. One AVN presentation is without joint space loss. Another AVN presentation is with joint space loss. So right side is with the joint space loss, and the left side is without joint space loss. The left side has recovered nearly completely, and the right side has developing joint space, which we never read in the book. That is the reason I say that everything written in the book is not correct. The book says once the joint space is lost, it will never reappear. But here you will see that the joint space has started reappearing, as well as The patient is gaining mobility. See again after 6 months. Beautiful joint space, no collapse, and congruent joint surfaces. No, walk is normal. The patient has no lurch or limp from in the hip, and see this is the range of, in the right side you see, which we say that the joint space once lost is lost forever. It is contradictory to our teaching in the textbook that the joint space have reappeared, and instead of going for a bony ankylosis, the left has completely recovered. The patient is a Muslim patient. I'm little apprehensive in the camera, but you can see that this is the perfect range of motion which has appeared in this patient. Now, stages in femoral head we don't want to discuss because everybody can read the books, but I should mention that there is a stage 0 as well, where only histological verification can confirm that patient is going, that this part of the bone is going into avascular necrosis. Now, stage 1 starts with a normal X-ray, but MRI CT scan getting positive. Stage 2 shows various geographical areas involved in AVN without collapse, and the degree of without an area of involvement can be A, B or C subtypes. Stage 3 is the first stage of failure. I am mentioning this because none of the advanced stages here is contraindication to my therapy. Stage 4 is evidence of flattening. Stage 5, above finding and decreased joint space. So I showed you a stage 5 case on the right side and the stage 3 case on the left side, and both the sides recovered. So I say, except stage 6 where there is a complete destruction of the femoral head, I say that the treatment is applicable to all the stages of avascular necrosis. Now, what are the principles of my treatment? This considers AVN is due to thrombosis of the solitary blood vessel supplying the femoral head. Thrombosis is associated with arthritis sooner or later, and that is the reason arthritis treatment along with blood thinner to clear up the thrombosis certainly works, because now hundreds of different workers from different part of the country has tried this therapy in their own patient, and they can also vouch for it. What are the merits of the regime? Now, whenever you pick up a regime, you should know the advantages and disadvantages. Now, the merits of the regime is that it reverses the thrombosis, reinstates the blood flow to the affected necrotic area. Creeping substitution replaces the dead bone into a living lamellar bone. This is a highly safe regime, tried and tested in arthritic patient for more than 6 lakh patients for many years from my side. And this I can guarantee to all my fellow colleagues. This is a highly safe regime, but you have, in spite of having said that, you should always intermittently go for the blood tests and annual ultrasound of the whole abdomen. Duration of the treatment 1 to 2 years, also depending upon the initiation of therapy and Ficat staging. Now, what are the limitations? Strictly avoid nicotine and alcohol, because these two habits prevent the development of new vascularization, new blood vessels. Avoid outdoor activity for initial 2 months, only indoor mobility. in order to avoid collapsing of the soft femoral head in ischemic area. Rest is best during a pain. In spite of the treatment, the patient can experience a bit of pain now and then. During that time, I suggest no painkillers, only rest, because rest ensures more efficacy of the treatment. Low doses DMARD, as I suggest, are safe. In spite of this, get regular blood test, once a year BMD, once a year ultrasound, and new X-ray pelvis 2 to 3 monthly, also with 30-degree hip flexion, because two ways you can see the head of the femur completely. One normal, another is 30-degree hip flexion. Blood test, I already told you, these are the simple blood tests you have to get repeated, and this is the way we can monitor these patients, and for 2 years. I give warfarin or heparin in the first month or 2 months, then later I switch on to clopidogrel and aspirin. In that condition, APTT, prothrombin time, APTT and INR also are required. All arthritic patients, as I said, are often should be monitored for fatty liver, for kidney stones, as well as for IBS. So supplement these patients with adequate amount of vitamin A, vitamin D, vitamin B12, protein, and probiotics. Thank you so much.
Thank you, Dr. Mukherjee. So elaborate and new things for the audience. We will have the discussion in the end.
In the end, yes.
In the meanwhile, I would request Dr. Jain to start sharing his screen.
Good evening, everyone. Today, my voice is slightly hoarse, so you may have some problem with listening, but I'll try my best. AVN as new Vistas. I started my own regime back in about 35 years back. And later I met Dr. Mukherjee, and I found his regime is far superior. But it is far complicated also. My regime, because of being simple, so I still continued my own regime, added few things from Dr. Mukherjee regime. So these new Vistas, Dr. Mukherjee has told very less. His topic was very long. I think he cut his time. His topic was very good. I heard everything from his previous topics also. So he has not told many things, nor I can, because I thought I'll have very less time here. Anyway, I'll give my own views, and these two are totally different from the Mukherjee regime. How? That I'll tell you. First thing, I'd like to inform you, this was from Laterale company, well-known company, manufacturers of Hatrogen. They said filarial arthritis in children, and they have given Hatrogen all children having arthritis, and they have found cure in almost every case. So what they have concluded, you see, conclusion was in filarial endemic zone, a high inducer of suspicion of filarial arthritis must be entertained in child when he presents with arthritis. This brochure of the company I have seen when I have discovered filaria as a cause of arthritis 10 years before. So I thought Latterly, company has disclosed my secret that I use to cure children's arthritis. And then later I started. What did I start? There is a surge in avian post-corona. This is related to the steroid use. Even teenagers affected. Early diagnosis with timely MRI may save thousands of hips. Early diagnosis to prevent damage. I have seen any case who is coming to me with a stage 1, he never progresses. And whatever stage the patient comes, he never progresses. Once I start my or Dr. Aroop staging. So early diagnosis of AVN is important to prevent consequent bone collapse. It is recommended that any large joint pain after COVID-19 should be taken seriously. How do I diagnose AVN? Any person having hip pain not diagnosed by previous doctor persisting for 3 months in young person, I consider as AVN. How do I confirm it? Restriction of internal rotation. I always advise them X-ray. If not, nothing is seen, I advise them MRI. So early diagnosis is very important. Then early signs are pain of the hip. Pain may be of the thigh. Patient is having difficulty to stand up and yell complaints. And many patients, they come with a history that I have been taking NSAID for many various doctors and pain is not going. And when they present to me a year or two later, till then the damage starts and they have series of X-rays. Initial X-rays showing nothing, later X-ray slight damage, and when they come to me, they have crossed already stage 2 or stage 3. A course of joint problems, avascular necrosis, another post-COVID problem. If Ortho Global, my group people remember, I have warned them in April 2020 that you will have flooding of cases of backache, sciatica, cervicalgia, and AVN. My group members may remember I have warned that AVN will surge. AVN mainly affects femoral bone head caused by interruption of blood supply, beautifully explained by Dr. Aroop already, causing death of the marrow and osteocytes and collapse of the necrosed part of femoral head. As COVID affects blood clotting, because you know very well that COVID causes clotting and it causes clotting in the femoral head as well. Theories, clots could be affecting blood supply of the bone tissues. It's only theory, nothing is sure. A study among the North Indian population found steroid intake was observed in 37% cases only. So majority have not taken steroids. And COVID is being treated mainly with the steroid. Patients feel severe pain from the dying bone. And later the patient suffers from the arthritis of hip because of the cartilage death and cartilage damage, causing stiffness, limiting movement. Many with the stage 4 AVN need hip replacement. India, 60% of hip replacement needed are due to AVN. So see, it's a major problem. 60% of hip replacement because of the AVN alone. This is the link, you can search on this. What it says the discovery of lymphatic vessels by Achilles in 1622. Many studies have been to determine the presence and distribution of various parts of the body, but little is learned about the function. The study of articular lymphatics was neglected until the interest arose in the complex anatomy and physiology of joint. I have been told by many doctors that bones do not have any lymphatic supply. True, bones do not have, but joints do have. So avascular necrosis of the shaft, you cannot receive the lymphatics, but the joint lymphatic fluid damage may cause stagnation of the tissue fluid and the reduced circulation and diffusion of the tissue. oxygen to the tissues. Lymphatics alone can reduce the back diffusion of the oxygen and cause avascular necrosis without affecting blood vessels. The study of articular lymphatic is neglected until the interest arose in complex anatomy. In the textbooks, anatomy, and even a larger atlas, one rarely finds lymphatics of the joint cavities. The normal physiology of lymphatics during joint cavity and the functional disturbances which they manifest in the disease are understood even not clearly. Bones do not have normal lymphatics. However, individuals with generalized lymphatic anomaly (GLA) or Graham-Stout disease develop ectopic lymphatics in the bone. So bone may develop in certain disorders. Recently, it has been demonstrated in murine models. Murine means that of rheumatoid arthritis that popliteal lymph node. This is a very interesting find. Popliteal lymph node is a biomarker of arthritic flare. As is expand in size, when the rheumatoid arthritis is not active, lymph node extends, and when the attack occurs, lymph node collapses. So this collapse size of the lymph node can tell the stage of the RA in murine model. The filaria bone link. We predict that RA flares that take place sporadically in patients with chronic disease are associated with the loss of lymphatic egress from the joint and can be assessed by the collapsed efferent lymph node and absence of a lymphatic pulse. With the recent development in clinical PDUS, pulse detector ultrasound, and NIR ICG imaging of the draining lymph node instruments to measure and assess the lymphatic pulse are now available, providing a unique opportunity to examine diagnostic and prognostic potential of these biomarkers. This I have already told. Until recently, the joints were thought to have no lymphatic drainage. Lymphatic drainage from the anterior aspect drained to the deep inguinal nodes, while the medial and posterior aspect drained to the iliac, internal iliac lymph nodes. You can see this diagram. This is the joint drainage. Normal hip joint, you can see the blood supply regular, and with the osteonecrosis, you see the black dying bone, disrupted blood supply in necrotic bones. This is my first long-term recorded case. This lady, AVN non-operative, follow 15 years. 40 years aged now. At that time, she was 25 only. In 2007, she was due for the bilateral hip THR for the moderate AVN. I don't have old X-rays. This is the current X-ray. Treated by bisphosphonate for 3 years, she remained well. X-ray of today done to C condition. X-ray may be not so good, but she has never complained since thereafter. She came out 3-4 years back. Then I have taken these photographs. She can sit, she can squat with a cross leg, and she is symptomless totally. Patient is taking lubricant tablet, one tablet since then daily as well. A new patient come today, interacted with this lady. At the time this lady has come, a new patient has also come. And lady assured that patient that see, my results are very good. AVN of hip is a mild disease, reduced to mild disease since the introduction of Igratimod, Risidonate, Ivermectin. This Igratimod I have borrowed from Dr. Aroop Mukherjee's regime. He was using these drugs and he was using methotrexate, but I am using Igratimod. Relief in a week, pain relief in a week. This is significant and the drug is very, very effective. This patient presented to me with a pain for last 1.5 years, not diagnosed. You can see even in 1.5 years, because he was not operated, so the collapse is mild. He was not treated. Relief in a week, and he was okay 5 months later. I called him. He is all right. The phone number is given. Anyone can call him. AVN patient, 1 year satisfactory relief. There's another patient on fusion regime of Dr. Diwakar plus Dr. Aroop. First time effect of bisphosphonate became clear. First few months he took alendronate, and whenever he changed to risidronate, a visible relief. The patient himself told that risidronate has given actual relief. So alendronate is not working. This is patient 42 years, 8-year-old AVN. 1 year back, this was the position. And when he presented to me, within a year, you see, a lot of damage has occurred. Catch AVN at the earliest. High suspects are antalgic. I think many of us are not antalgic. Algia means, algos means pain. Antalgic means no pain. Antialgic. The patient, he assumes his gait to avoid pain. That is known as antalgic gait. In youngs for 3 months or more, restricted internal rotation. These are my criteria. They are not described anywhere. These are, I formed these criteria. Antalgic gaits, young for 3 months or more, restricted internal rotation of hip. Initial X-ray 2 years back, when he came with the X-ray, and he came 2 years later and there was slight damage. The ortho who saw this case 2 years back did not suspect AVN, as he forgot to test internal rotation of hip in vague pain around the hip and kept him on NSAID and calcium. This is very, very bad thing that we are using calcium in every bone disease without giving diagnosis. Now landed in full-fledged AVN. Now surgeon advised THR. I'm sure I can revive my own regime, painless hip, in 3 years. My regime is 3 years. Dr. Aroop regime is 2 years. Many unsuspecting doctors advise knee X-ray. I tell you one very interesting thing. This is X-ray of a doctor. He is a surgeon himself, and he has joined the meeting. He is listening it. He had very, very mild AVN 1 year back. Then he underwent core decompression and stem cell. Left hip is still okay, but right hip degenerated within 5 months. You can see. And MRI now, he's going to have MRI, this THR soon. So many unsuspecting doctors advise knee X-rays because patient come with the knee pain alone. And they argue with me that why hip X-ray? I am having pain in knee joint, take X-ray of the knee. This is because hip pain is referred to the knees. That delays the diagnosis, particularly in small children. Small children, they never come with hip pain. Caught early, AVN is fully reversible. Core decompression in early cases met with a 50% success only. Full collapse as early as 4 months seen in this case following core decompression. My regime is totally different and totally unknown, and I have been silently practicing this regime for last 40 years. I bandronate because this is once a month, 150 milligram once monthly for 3 years. Beta 6 block, this I have added since I invented this beta 6 block. This I invented in 2018, and I'll tell you in following slides what this beta 6 is. Igratimab 25 milligram daily, since it has come for last nearly 1 year. मोबाइल देना, इन्होंने बंद कर दिया होगा. I think, can you hear me? I'll connect again.
Yes, I can hear you.
Now you can hear.
Yes.
We can hear you. Carry on. Carry on.
Okay.
We can hear you, sir.
Okay. I bandronate 150 milligram monthly for 3 years. Beta 6 blocks SOS for the pain. And you wonder, beta 6 block is a sort of particular point, sole Gialucan 0.3% injection. Injected in AVN, I need to repeat only once in 7 days. I don't use any NSAIDs. I use only beta 6 block. Effect lasts 7 days at least. Albendazole 400 milligram ivermectin for my filaria theory. Collagen tablet for regeneration. No NSAID or steroids. stop tobacco, control diabetes and exclude TB, vitamin D injection 6 lakhs once a year, and once weekly iron supplement. You will wonder iron should never be given daily because of the hepcidin production of the liver. It blocks the absorption if you give daily. So once weekly iron is sufficient. This is what beta 6 block is. This is page from my book. It is 1 inch lateral to the femoral nerve, just below the inguinal ligament. You inject inside the muscle 1 ml of the 0.3% diluted, 6 times diluted Jalocan 2%. And you wonder, this is not anesthesia. It is a portal point which, with the unknown reasons, gives relief days to years. Longest noted pain relief with single injection is 2.5 years. So in AVN IC, patient require injection once in a week. This is my book, second edition. You can see physiological pain portals. There are many pain portals in the body. We have discovered about 30, 40 so far, and it keeps on increasing. Every month passes. And it's a superb pain reliever in fractures and mediocre pain reliever in neuralgia. In neuralgia, it is not 100% effective. In fracture pain, it is 100% effective. In AVN, it is 100% effective. You choose the right point and you have long-term pain relief. This is same book translated in Italian by Dr. Mario Tangari. So my take-home message, resorting surgery in early cases is unwise. High suspicion should be taught to us. Prudent trial saves hip. You should try either of the regime, non-surgical, because total hip replacement is ultimate. So why not try a safer regime which can save hip? And you can learn from Dr. Magu. He says hip joint doesn't belong to dustbin. It belongs to the hip itself. So that's what we follow. We say hip joint belongs, saves hips. Surgery many times is on demand. Patient demands, I have too much of pain. Go for the surgery. And we have to go for it. As everyone wants to resume routine quick, option of non-surgical must always be offered. We should offer them. If it is not relief, THR is very simple and everyone can do it. Thank you so much for hearing. Now the session for the questions.
Thank you, Dr. Arvind.
Excellent talk, sir. Excellent.
Dr. Prakash, sir, please unmute yourself. Sir, please unmute.
Yes, I have unmuted with your permission. I just asked my hand up to unmute.
Yes,
Both
sir.
Sir and Dr. Aroop have been my very close friends for the last 7 years, and I have been propagating their radical ideas. As far as I am concerned, I had treated less than 10 avascular necrosis before the COVID era. But in the COVID and post-COVID era, my total is 76 patients. I have not tried the filarial part and ignored part of Dr. Diwakar because I practice in Tamil Nadu and Kerala where filaria is not endemic. But I have used this regime with minor modifications with fantastic results. So what moral I could learn from his regimes and the theories were that you put into the dustbin at any age. You can replace the hip at 30 or 40 or 50 or 60 or 70. If there was any way to delay hip replacement to 5 years, 10 years, you take valuable time to make your patient happier for that much more. Times, after 3, 4, 5 years of medical treatment, the patient is so happy with his functional status, irrespective Think of the bizarre radiology which would make a senior arthroplasty surgeon's fingers itch. Hey, tomorrow I must go and do a surgery. The patient is so happy, squatting, sitting in the toilet, doing namaz, pain free, that he doesn't want surgery. And by luck, I had recently gone to Calcutta for that rheumatology conference, and one of Dr. Mukherjee's avian patient treated about 20 years back came and saw me, and there was no time for us to show that patient in the conference. But that man is working as a welder. He sat on the floor, he squatted, he did all that, he did all acrobatics. He's not taking any medicines. All it took was about 2 years of Dr. Mukherjee's medicines. So that is how long it lasts. So he was treated when he was 25, now he's about 45, 50. He doesn't want a knee replacement. The only criticism we all face is that there are no publications. Dr. Mukherjee doesn't need a research team. Dr. Mukherjee is lazy. Collecting the references, and hopefully in another 12 to 18 months, we should be able to get an official publication about Diwakar. 6 blocks have already found mention in international, prestigious HIP International by the states. We have treated about 170 trochanteric fractures by just Peter's block and walk. And that should be a topic for another webinar some other time. So for now, for all our viewers, open mind. When you find avian, don't rush for a THR. Give some 3 months, 6 months of medical treatment, no analgesia. Neither Mukherjee's treatment or Diwakar treatment use any NSAID. Drugs are safe. And let's see how the patient does. If he does well, why not continue 18 months at my revascularization? Okay. Anyway.
Yeah, thank you, sir, for your valuable advice. I would like to ask Dr. Mukherjee, sir, you recommend the treatment for 2 years, and what's your longest follow-ups, and what's their condition clinically as well as radiologically after stopping the treatment?
The thing is that, see, I told you the reason is pain. The pain has got maybe 2, 3 reasons of pain. One is an inflammatory attack. Second is an ischemic attack. Third is a neurological attack. Fourth is a fracture. Why does a hip pain? Hip pain due to inflammation, due to ischemia, due to neurological irritation, and due to fracture. These are the four causes. Now, that is the reason every 3 months we should repeat the X-ray of the patient in order to make sure that there is no further collapse. So it is very necessary to get a preliminary hip X-ray in AP view, pelvis AP view, and pelvis AP view with hips joint 30-degree flexed, so that the head rotates upwards and you can see the entire head or the geographical area involved. Now, why does a head collapse?
Sir,
Yes.
excuse me. My question is that after your treatment for the avian,
Yes.
ischemic hips, what's the effect of the treatment after the effect of treatment lasts for how many years?
For lifelong.
Correct.
For the lifelong. Once
The long follow-up of your avian treatment after stopping medicines, which has not required a THR.
which does not require it. Yes.
So, no, his question is very clear. In years, what is the longest period a patient has survived on his own hip without THR after your regime?
See, the patient usually we are practicing in private, and when most of my patients, they are off the treatment after 2 years. But sometimes they complain about the pain. I start the regime for a couple of months and then again it goes into remission, because the primary pathology may be an inflammatory attack. So that is the reason.
Dr. Siroli, what number?
Maximum period is 20
What is the
years.
longest number of years you have
Because I think I am chasing.
I have 35 years follow-up without requiring second.
No. I think I am seeing these patients for 25 years maximum. And nobody goes for a hip replacement yet. 25 years is what is end of the last century, and even today they are coming.
So I think Diwakar 25-year follow-up and Dr. Aroop has a 25-year follow-up.
25 years.
And published. That is what is important.
Dr. Puneet, any questions from the audience to your side?
Please have to unmute his mic.
Unmute your mic.
Sir, Dr. Imran Akhtar is asking what assurance we should give given to patient before starting the treatment to Dr. Mukherjee.
I think what I give them assurance is that a younger patient is not fit for a THR, it's not a proper candidate. First assurance that you have got no way, there is no way that somebody can assure you a treatment without surgery. If you are subjecting the patient to surgery, the arthritis and the ischemia will flare up and can lead to collapse. Most of my patients, they never come with a collapse. And that is the reason I tell that when you initiate the treatment, then you always get a baseline X-ray from same place. And every 2 to 3 months, you keep on repeating, and you will be surprised that since the start of the treatment, there is no deterioration.
Fine,
I remember only 2 patients who have deteriorated after the treatment. One was a chronic alcoholic and another was a tobacco addict, whom I said that you have to quit tobacco and alcohol as well. So these 2 patients have deteriorated because of the collapse. The first thing is to maintain the structural integrity of the hip.
Okay, sir. Sir, what usual complication you encountered in your treatment part, sir? Usual complications.
Usual complications are first thing that these are not a complication of the treatment, because see, this is a standard treatment I use for the treatment of rheumatoid arthritis as well as general arthritis. So the treatment is the same, except that for AVN I use a blood thinner, and for osteoarthritis I don't use a blood thinner, or rheumatoid arthritis I don't use a blood thinner. So the complications are the same as described in the books regarding methotrexate, regarding sulfasalazine, regarding refunamide, same. But because the drug doses are very minimal, so we don't see that many number of complications. At least I don't see that many number of complications, because my patients keep on coming back to me because they are getting better.
Sir, so the message should be that the treatment starts before the collapse, number 1.
No. Even if it has collapsed,
Okay.
and it is because of the fracture neck femur also. Suppose in a patient of fracture neck femur, somebody has done a multiple hip screw and there is a partial collapse or avascular necrosis of the femoral head, or there is a posterior fracture dislocation of the hip in a road traffic accident, which we commonly see.
Yes.
Then also it leads to avascular necrosis, right? So in 20% of the hips which are subjected to internal fixation, there is an AVN. And posterior fracture dislocation of the hip invariably goes to AVN. In those 2 conditions, I now regularly keep my patients for 1 year of my regime, and one of a radiologist here who sustained a posterior fracture dislocation went for a surgery And I told him immediately start the regime, and his head is as vascular as a new head. But most of the doctors will warn the patient, his head can go into avian, but they can't do anything. But they don't know a regime which is safe and which can be started then and there. I am seeing our past one of the doctors of IOA who had a posterior dislocation and now is under the treatment is much better. So it is not an inflammatory disease only. The treatment reverses the thrombosis and increases the vascularity of the femoral head.
Sir, one question, like, sir, what DMARDs you are preferring in what doses
I use 4
and
DMARDs.
what blood thinner?
I use 4 DMARDs. One is a methotrexate, second is a sulfasalazine, third is a HCQS, and fourth is a 2 milligram steroid, 2 milligram Medrol. So when you see my prescription, you will find all the DMARDs there. But one is taken twice a week, one is taken thrice a week, and Medrol 2 mg is taken every day at night, half a tablet. That means 2 milligram, along with ecosprin subsequently, and protein supplement and probiotic. Yes, tell me.
Fine, sir. And what blood thinner you are preferring, sir? Heparin or
Initially
warfarin,
90 days or 100 days warfarin. 2 mg warfarin every day, 6 days a week, except on Sunday. Empty stomach for 90 days.
Okay, sir.
And then replace it with ecosprin.
Clopidogrel, ecosprin or clopidogrel.
You can go through the regime, it is there in the Google.
Mukherjee has not explained it very clearly. I will summarize it very, very clearly. Only the heads with singular vascular supply go for AVM.
Yes.
Multiple vascular supplies do not go for AVM. Cause of AVM is obliteration of these vessels by either amyloid or inflammatory conditions. Methotrexate is the one that acts on rapidly proliferating cells and thereby stops their proliferation to allow blood to go in. But to stop methotrexate from affecting other rapidly proliferating cells in the body, we neutralize it with folic acid and we add blood thinner to ensure that the drugs reach the spot. That is all.
Yes.
And the food and other things are ancillary, building up the building. But the crux of the tip is that either amyloid or multiple proliferation, cellular proliferation causing obliteration of the solitary vesicle, a combination of methotrexate and folic acid very safely opens up the channels and blood allows the medicine to reach in and revascularize that. So this is what should be the take-home message today. The prescription exactly as Dr. Mukherjee has put, we can put it in the group, it has come on the screen, they can follow it just like that. It's okay. But what Dr. Diwakar, I and Mukherjee have understood is that increase the blood flow and protect no painkillers, no anti-inflammatory drugs, and hopefully had stayed alive for a few decades or more. Thank you.
Thank you, sir. Thank you, everybody. I think the message is clear.
Unmute if you want to speak.
Dr. Jain want to say something, sir.
Yes.
Dr. Jain, sir.
Speaking with the mic.
Unmute, sir.
Unmute, sir.
Unmute your mic.
Yes. So now you have seen there are two different regimes, totally antagonistic to each other. That means both the theories are at work. I simply release the egress. Dr. Mukherjee start new blood flow. So one pushes and I take it back, and both way it works. And I have seen many patients of Dr. Mukherjee whose hip have regenerated. Although I have done only hardly 200 cases, Mukherjee must have done more than 1,000 or 2,000-3,000. But long-term follow-up has told that any patient who is relieved of the pain gets always cured, and I needed always 3 years, not less than 3 years. 3 years the minimum which I give. And my regimes are simple because though maybe some expensive 500 to 600 rupees a month, but ultimately total treatment will never go beyond 10,000 rupees. And pain relief, because of the beta 6 block, pain relief is instant. The person suffering pain for last 1 year or 2 years, he goes back walking comfortably from my clinic. So with the beta 6 added to any regime, it's very good. It doesn't fail in vascularization, but my collagen addition always helps in regeneration of the cartilage. And as I have just written, I regenerated my own knee cartilages twice, once 30 years back and another 10 years back. My MRI has been seen by many of my colleagues, and knee joints were degenerated. It was subluxating. So I have seen the cartilage is regenerates, provided you use collagen and exercise. Exercise means the pressure generating motion, the joint always regenerate cartilage. That's why I never give rest the Parthis or AVN. My all Parthis they recover with the same regime because I consider Parthis as a children AVN. So both the regime work. Some people are afraid to use steroid, but they should not. I don't use steroid because I never need it. Whatever I am using, I never needed NSAID, I never needed steroids. So it works without steroid, but recently addition of the Igratimod has hastened the results. So I have added now. This I have borrowed from Dr. Mukherjee. So I think the regime should be tried. If you give beta 6 block, the instant pain relief is there and patient is happy. Then give any regime you wish. And if the progress halts, you need nothing. And I don't think core decompression is of any help because in whatsoever patient I have used, no one has any stoppage the process. So this is what I have to say.
I think Dr. Diwakar should always tell people about the level of physical exercise he does on a day-to-day basis. It is astonishing that at this age, he swims 5 days a week, I think, 1 hour every day. Whether it is a chilling cold weather, whether it is a hot weather like this, he swims 1 hour in the reservoir near his house, wherever it is, for many, many years. That level of physical exercise can cure all sort of arthritis. But that is very rare to see a man of his age doing that sort of an exercise. So in spite of a bad knee X-ray picture, all the footballers, they never complain about their pain in the knee. You can see the X-rays astonishingly bad. You can call it degenerative, you can call it whatever you feel like, but they will always walk straight, very powerful people, and they never complained about the knee pain. So exercise is the best way to treat arthritis, but these days, because of petroleum products, electricity, we rarely work hard physically. That is exactly why it is rampant also.
Dr. Jain,
Thank you, sir.
by the exercise you meant weight bearing exercise or quadriceps exercises? You told about the exercises in children also. So you
Dr. Jain, sir. Dr. Arvind Jain, sir. Are you listening?
Yes. Yes,
you told about the
Sir,
exercises.
Dr. Sir is having
Uh,
query regarding the mode of exercises, closed chain exercises, open chain, isotonic, isometric, which kind of exercises you will advise for?
actually, some Arabian physiotherapist has taught me Murugan's exercise. So that worked in my knee last time. Everyone told me that you have to get knee replaced this time. You survived in 1995, but this time you'll not. But Murugan's exercise is an exercise in which non-weight bearing, pressure creating motion, like say sitting and lifting weight with the knee. So
okay.
non-weight bearing, but some pressure and motion. This is Murugan.
Okay.
So this exercise, it regenerates because it pumps the extracellular fluid outside the lymphatics, which allows new tissue fluid to diffuse inside. Artery alone cannot help because artery never supplies the tissues. Artery gives ECF, extracellular fluid. This extracellular fluid goes to the tissues and the fluid is drained to lymphatics. If there is no lymphatics, blood supply never goes to the cells itself. It goes through extracellular diffusion, and that extracellular diffusion has to go into lymphatics. It cannot go into vein. Artery empties into vein. Artery never supplies blood directly to the any tissue of the body. It has to be through ECF. So I am still sure that bones should also have lymphatic drainage, because blood supply can never bath the tissues. It has to come through ECF, and ECF has only one drainage, that is lymphatics.
I think bone is known for thrombosis in the Haversian system. Is everybody hearing me? Yeah,
Yes,
the
yes.
bone is known for thrombosis in the Haversian system. Whenever there is a fracture, there is a word called terminal bone death.
Yes.
If you read your Watson Jones on your old books, they will
Charlie
talk
also
about
says.
the word called terminal bone death. That means a shattering injury shatters the bone, and certain part of that fracture area, that length may vary with the amount of energy, that goes avascular. And that is the reason that terminal bone death gradually comes back to life. This is a milestone in understanding of this about bone physiology and function of this century, that a bone which is dead today, because two dead bones cannot unite, a dead bone will have to come to life, because before it unites with the counterpart fragment. So that is the reason at times we see there is a jumping callus, that is a callus which is jumping from the living bone to another fragment area which is again live, and that last part which heals is that fragment with which that surface which are facing each other. So there is a callus which is called as a jumping callus, which arises from a living bone and connects to a living bone, and this part of the bone which is dead will come to life slowly. That is the reason in a young man it is recommended that you put the bone in as normal hairline reduction, so that the remodeling of the Haversian system is undertaken minimally. Otherwise, in a young child, the vascularity is very good and the huge callus formation also happens, which bypasses this terminal bone death segment. I hope I have made it clear that bone death is never a permanent feature. It is never replaced by fibrous tissue. It is replaced always by a living bone.
Yes. So I think, sir, there has been enough discussion and it has been very beneficial to the audience. We will be having webinars on different topics on every second and fourth Thursday of the month. So keep tuned to us, and I would request Dr. Puneet Agarwal for a vote of thanks to the audience and our speakers and panelists.
Thank you, sir. Thank you, Mukherjee, sir, for a wonderful talk. Such basic things you explained to us. And thanks, Dr. Jain, sir, for your new regime. And thanks, Dr. Prakash, sir, for giving your suggestions. And thank you, Dr. Siroli, sir, for moderating the session. Thanks to OrthoTV team and Dr. Ashok Shyam, sir. Thanks to all. Thanks to delegates. Thank you, sir.
Good night, sir.
Good night, sir.
Bye.
Ashok, Shyam, and Neeraj, Bijlani for all the hard work they have done. And extra thanks to Dr. Siroli and Puneet for the troubles they have taken to bring in something
Thank you,
unexplored. And nice talks by Aroop and Arvind. Thank you very much. Good night. Bye.
Sir, I got the inspiration from your
Thank you, sir.
Talk about the Mukherjee regime, sir, and my talks to Dr. Arvind Jain, and then I thought that this topic should come to the Thank you.
Thank you, sir.
You are muted, Dr. Jain. Dr. Arvind, you want to say something? Please unmute yourself.
Yes. So
Yes.
thankful to you, Dr. Siroli. And I think you send me this link also. So we'll post it, and many of the hips will be saved from now on. Thank you so much.
Thank you, sir.
Thank you, sir.
Good night, everybody.
Good night.
Good night.